Good evening, everyone. And I think good morning for Dr. Connors in Vancouver, and good afternoon for other people because of the different in time zone. This is Dr. Al Mansour, medical oncologist, section head of medical oncology, Princess Noor Oncology Center. I would like to welcome you and thank you all for joining us tonight for the SSBMT webinar. As you know, this is a weekly activity organized and led by Dr. Ahmed Al-Askar with the SSBMT. And the how I treat is the series that we have. The first one of them today is how I treat, and the next week will be how I treat the AML. In July, then it will be switched to a weekly Wednesday, and the schedule will be sent to everyone. It gives me a great pleasure to introduce tonight Professor Joseph Connors from British Columbia Cancer Center. I think he is well known to all of us, and his contribution and impact in the lymphoid malignancies, mainly in the Hodgkin lymphoma, is very well recognized and appreciated by the everyone treating lymphomas. Professor Connors, his name linked to the major advances, mainly into the Hodgkin lymphoma over the last 25 years. He is currently Emeritus Professor at British Columbia Cancer Center for Lymphoid Cancer. He was the chair for the lymphoma tumor group at British Columbia Cancer Center, and also the director for the BC Cancer Center lymphoid cancers between 1989 and 2018. He published more than 400 peer-reviewed articles. And on the personal level, I was one of those people, and I was lucky to be trained in Vancouver, and would like to thank also Dr. Connors for being a great mentor and a great teacher for us during our fellowship. And I think his personality and practice impacted everyone treating lymphomas who joined the British Columbia Cancer Agencies. And we learned more than a scientific knowledge. I think we learned many things in conducting the research and criticizing articles and dealing with patients and families and presentations and many, many things. So I would like to thank Professor Connors for joining us tonight and sharing his experience in the management of advanced stage Hodgkin lymphoma. It will be for 25, maybe 20 minutes, and then we'll take questions from the audiences, and we have a good time to have a discussion. So welcome, Professor Connors, and thank you again for joining us tonight.
Thank you very much. It's my pleasure to have the opportunity to do so. So I'm going to be discussing Hodgkin lymphoma, and I think to make it the most useful, I'm going to have a pointer that I'll be able to use. And I've chosen to focus on this by answering some specific questions about the choices that we need to make in deciding how these patients should be treated today. Let's see, I have to remember exactly how to advance my slides. So that's, yeah, good. So this is my disclosures. It's important for you to understand that my institution and my work has been supported by the pharmaceutical companies that you see named there. And I have received honoraria and travel expenses from Seattle Genetics and Takeda Pharmaceuticals, the manufacturers of brentuximab vedotin. I'll mostly be discussing brentuximab vedotin as a new agent, and I may mention some of the checkpoint inhibitors like nivolumab or pembrolizumab, especially in the question and answer period. So let's see, I have to figure out how to advance my slides. If I choose the slide, that works. So I think the key issue today in deciding how to sort out the approach that we should use for the patients with advanced stage Hodgkin lymphoma can be reduced to deciding about the use of PET adaptation, that is the use of interim PET scanning during the course of treatment, and the role for novel agents, which will be continuing to evolve as the newer agents become available. We should start by defining what we're talking about. So by advanced stage disease, I'll mean patients with stage 3 or 4 by the Ann Arbor scheme, or those with the presence of B symptoms, or with the presence of bulky disease at any site. In each of those cases, I would consider the patient to have an advanced amount of cancer and to need treatment. And you can see the choices that one might use here reduced to initial chemotherapy. I think today most of us can agree that 6 cycles of chemotherapy is the sensible treatment that these patients should receive. And at the end of the chemotherapy, if a complete response by PET scan has been achieved, treatment can stop. If the PET scan is positive, then I think it's appropriate for the patient to receive radiotherapy if that can be confined to an involved field of radiation. If the distribution of the disease is wider and not suitably treated with involved field radiation, a period of observation is appropriate. About 20% of the patients will actually remain free of progressive disease, but the majority will then progress later and require an escalation in treatment that we won't be discussing today. But that's the overall approach that I think should be taken. To begin with, it's important to understand how often interim PET scanning is positive. And I've stated it by noting the obverse here. You can see the list of studies that have employed interim PET scanning after 2 cycles of chemotherapy. And typically, the negativity rate is about 80%. And those patients then go on, while simply completing treatment with the same treatment they've already been receiving, to have a progression-free survival of about 80%. So the PET-2 scan is strongly predictive of outcome and can reassure us that it will be appropriate to complete treatment as it already has begun. So using that test, I'm going to go on and examine the results from 3 different large prospective randomized trials that have helped us to understand the role that one might use this PET scanning, interim PET scanning, in the management of patients. And I've listed trials that have employed 2 different types of chemotherapy. The Rathel trial looked at ABVD and an interim scan after 2 cycles. If the PET scan was negative, the patients were randomized. In the HD18 and AHL 2011 trials, the initial chemotherapy was escalated BIACOP. And then the scan was done, and the strategy altered depending upon the result of the PET scanning. The experimental arms are listed for you there in the second red box, and you can see in the Rathel trial, it was a simple strategy. A negative scan led to dropping of the bleomycin in the experimental arm. In the 2 BIACOP studies, de-escalation was employed. In the HD18 trial, the de-escalation was to reduce the total number of cycles of BIACOP to just a total of 4. In the AHL 2011 trial, the de-escalation was to shift back to standard ABVD, that is, reduce the intensity of the chemotherapy. So let's examine what happened when these strategies were employed. Here's the scheme for the Rathel trial. You can focus on the red boxed PET negative section of the patients. 80% of the patients wound up PET negative after 2 cycles of ABVD and were randomized to continue ABVD or drop the bleomycin and just treat with AVD. When that was done, it was a tie. The PET2 negative patients could have the bleomycin eliminated, and the outcome, the progression-free survival, was the same as would have been achieved had the bleomycin been retained. So the trial was a success and defined the fact that one could drop the bleomycin, de-escalate by dropping one of the chemotherapy agents from the ABVD. In the cases where that's done, you can look and see just how much potential toxicity has been avoided. And you can calculate that about 55% of all of the bleomycin that might have been given, had one not changed treatment based on the basis of the PET scan, that 55% of the bleomycin would have been avoided. So there's a toxicity avoidance that's been achieved. If we look then at the German Hodgkin study group HD18, we have a different strategy. The patients initially are treated with escalated BIACOP, and the patients who are PET2 negative are then assigned either to standard treatment or to a de-escalation by reducing the total number of cycles of the escalated BIACOP. Once again, a tie. 5-year progression-free survival is the same on each of those two arms. And we can conclude sensibly that if the PET2 is negative, it is safe to de-escalate these patients. But I do draw your attention to the larger outlined red box there, where you see that only 52% of the patients turned out to be PET2 negative. This is a surprise because we would have expected with a more intensive chemotherapy to have an even greater number of PET scans be negative than we would in comparison to ABVD, and the opposite occurred. And we can only conclude that the chemotherapy itself, and perhaps the interpretation of the PET scans, was different. So if we look to see the, let's see, I've got to make sure I can, keep track of which slide I'm talking about here. So this is the interesting part. The way that the PET scan was defined to be negative was different in those two trials. And you can see it was only considered negative on the HD18 trial if the Duvel score was 1 or 2, and you get this near 50-50 split. If in fact you go on and change the definition to shift and include the Duvel 3s, you get something more like the 80-20 split that is seen with ABVD. And so it means that it's very important how one defines the negative PET scan. If we go back then and take a look at the impact, we can see that it is logical to make the split. If you look at the graph on the left, you can see that the Duvel score 1, 2, and 3 patients do about the same. And it's only the Duvel score 4 patients that have the modestly inferior outcome. Or grouping them together on the right, you can see that the most logical place is to split between 3 and 4. So an important aspect of the definition of PET negativity to keep in mind as the trials are carried forward. If we go then to calculate what's being avoided, how much toxicity is being reduced, following that strategy, the HD18 strategy of shortening the chemotherapy for the PET2 negative patients, about 25% of the BIACOP exposure will be avoided. And now on to the final trial of these 3. Here we're looking at the likelihood of the outcomes that we see in the AHL 2011 trial. The standard approach was to simply treat all of the patients with 6 cycles of BIACOP, regardless of the outcome of the second PET scan, the interim PET scan. The experimental arm, the PET-driven arm, chose to de-escalate treatment for the PET2 negative patients by dropping back to ABVD instead of escalated BIACOP. And you can see on the far right-hand side that the 5-year progression-free survival is the same on both the standard and the PET-driven arm. And now we have another special aspect to interpret the scans. Oops, I better go back here and use my pointer for this. So I'm going to go here. Let's see. There's the graphical comparison of the outcome for the standard versus the PET-driven strategies. And if we go back to the red box that's in the lower left-hand side, once again, the definition of PET2 negativity was altered. And now you can see it's going to be called negative if it's a Duvel score 1, 2, 3, or 4 with a low SUV, and only called positive if it's a Duvel score of 4 with a high SUV or a Duvel score of 5. So to make the strategy work, we have to change the definition of PET2 negativity. If we do that, we can then see the distribution of the patients. In the experimental arm, 85% of the patients are able to avoid continuing the escalated BIACOP. They're able to drop back, de-escalate to ABVD. So a lot of escalated BIACOP is being avoided. And that then allows us to take a look at what's been accomplished in terms of toxicity avoided. And you can see about 55% of all of the escalated BIACOP that might have been given to patients is now being dropped, because these patients have been able to drop back to ABVD and avoid the intensive chemotherapy-related toxicity. So again, once again, but in each of these cases, it's depended on the use of special definitions of the PET2 negativity. And most important to me, if we sort of summarize this, we can say that you can reduce toxicity if you start with ABVD. You have a way of dropping the bleomycin. If you start with escalated BIACOP, you have a way of either shortening the total amount of chemotherapy or switching back to less intense and less toxic ABVD. But in each of those strategies, what you're doing is avoiding toxicity. What we really need to examine is the question of, can you make things turn out better for all of the patients? That is, does PET-adapted treatment actually improve effectiveness of the primary therapy? To look at that, I have to turn to a couple of trials, one of which I've already mentioned, the Ethera Trial, summarized at the top there. That's the one we already discussed. And a SWOG trial. Strategy of both of these trials was rather similar. In the Ethera trial, if the PET scan was negative, on the left, there was the choice of dropping out the bleomycin. If the PET scan was positive, in 20% of the patients in which that occurred, then the patients were escalated up to BIACOP in one of two versions. Turned out the outcome for both of the different versions was the same, so we can simply declare them to be escalated BIACOP. In the SWOG trial, the strategy was the same. PET2 negative patients remained on ABVD. The PET2 positive patients switched to escalated BIACOP and received 6 cycles. And if we look at the outcome for the patients now, on the left-hand side, you can see that indeed PET2 negative patients did better than PET2 positive, but the PET2 positive patients did reasonably well, getting up to about the 60% mark because of the escalation that was given to them. But most important to me is to shift over to the right side, where we look at the overall outcome for all of the patients on the trial, both the PET2 negative and the PET2 positive patients. And there you can see that the 5-year progression-free survival is still a somewhat disappointing 74%. So what this means to me is that the PET-driven approach does accomplish a very valuable goal, reducing toxicity, but it has only the most modest, if any, impact on the effectiveness for all of the patients being treated. If one starts with ABVD, there's about 15% of the patients who turn out to be PET2 positive. They wind up being switched and getting perhaps a slightly better outcome. If you start with the escalated BIACOP, then the de-escalation doesn't lead to more people being cured, it just avoids toxicity. So ultimately, the integration of PET2-driven decision-making most accomplishes a toxicity reduction and has a modest or minimal impact on overall effectiveness. So I want to involve, in the end of my discussion here, a description or a discussion about a different way to try to improve effectiveness, and that's by adding a novel agent. So we're going to, of course, look at the Epsilon1 trial. At the bottom of the slide, you can see here that we're going to treat the patients with either ABVD on the standard arm or AVD, with the bleomycin dropped out and brentuximab introduced on the experimental arm, and the patients will receive 6 cycles of treatment. Now, I have to back up and say, what do we expect we might accomplish? To think about that, I want to go to a different trial that you'll be familiar with, the Ethera Trial. These were patients who had relapsed Hodgkin lymphoma, went on to a high-dose chemotherapy and autologous stem cell transplant, and experimentally, patients were given brentuximab vedotin on a control arm. They were treated with placebo. You can see here that the difference in outcome is about a 20% improvement in the patients who received the brentuximab, which implies that adding some brentuximab for consolidation can cure about a third of the patients who weren't cured by either ABVD or by high-dose chemotherapy and autologous stem cell transplant. So that leads me to think that if we look then at the Epsilon1 trial, that we'll hope to see around a 30% improvement in outcome. The trial itself was a straightforward design. Patients with advanced stage disease, in this case only patients with stage 3 or stage 4 disease, were randomized to standard ABVD or brentuximab plus AVD. A PET scan was done after 2 cycles, but the patients essentially were not changed in terms of their treatment. A few patients were allowed to change if they had a Duvel score of 5, but when the trial was completed, that turned out to be a tiny minority. So this is not treatment crafted by PET scan outcome after 2 cycles, but all the patients are completing their treatment based on the original assigned treatment, ABVD or AVD plus brentuximab vedotin. You've seen these results before, but I can give you the updated 4-year results from the trial, and you can see that there's a consistent and persistent outcome improvement brought about by adding the brentuximab and removing the bleomycin. The numbers are on the right-hand side. You can look at the 4-year progression-free survival, 82% versus 75%. And this implies that about 28% of the relapses we would have expected to occur, that is 25%, about 28% of that has been avoided, which I think is a very close match to the approximately 30 to 35% that we would have predicted would occur based on the Ethera results. And so I do think that the trial accomplished what it was hoped it might accomplish, and it reduced the likelihood of relapsing with your Hodgkin lymphoma if brentuximab was substituted for the bleomycin. So I told you that in that trial, a PET scan was done after 2 cycles, and we can then look at what happened to the PET scan patients. And of particular note are the ones I think are in the bottom red box there, where you can see that in the patients under the age of 60, who, remember, might have been considered eligible for an escalation to BIACOP, but in this case, where they simply to continue on the experimental arm, about 62% of these patients wound up with a favorable outcome, a progression-free survival. That's a rival for what we saw with the patients on the Rathel trial and the SWOG trial, where the patients who were escalated to escalated BIACOP had an outcome up in the 60% mark. So what we see here then is a different strategy. Ignore the PET scan result in the sense of changing treatment, but carry on with the assigned treatment, the brentuximab plus AVD, and one winds up with an outcome that's not as good as we would like. Of course, we'd like to cure 100% of the patients, but at least 60% of them remain progression-free in the patient population that would be suitably considered for possible escalation. Well, all of this comes at a price. That is, treating a patient with escalated BIACOP causes more toxicity than if a patient is only treated with ABVD, or treating a patient with the brentuximab addition to AVD also introduces the possibility of greater toxicity. So I've summarized here briefly the major toxicity to compare the results. And if we drop right down to the sort of the very bottom line here, you can see that fatality due to the treatment is about the same in all of these different approaches. And so as a broad statement, I'm going to say that the toxicity is manageable, whichever of the strategies that you undertake. But it will differ in terms of type, depending on the intervention that you've chosen. If you use standard ABVD, the biggest worry is going to be the pulmonary toxicity. The rest of the toxicity is manageable. If you choose escalated BIACOP, and now you're limiting yourself to patients under the age of 60, you still have to worry about febrile neutropenia, and there's a modest level of pulmonary toxicity. If you switch and consider using AVD plus brentuximab vedotin, the major toxicity that jumps out is neurotoxicity. Fortunately, it's manageable toxicity. If you alter the dosing, you can manage this, and it does resolve when the patients go off treatment. Febrile neutropenia still requires the use of growth factors, but pulmonary toxicity has been essentially eliminated. And as I said at the beginning, fatality due to the treatment itself is held to the minimum we would like to see in this otherwise relatively healthy population of 1%. So to briefly summarize, I think today the sensible options for treatment are either to use PET-guided approaches if you're going to use ABVD or escalated BIACOP when you start, or I think potentially even better is to introduce the novel agent, the brentuximab, and treat patients with AVD plus brentuximab vedotin, where with a manageable level of toxicity, it's reasonable to anticipate that the outcome will be an improvement over what would have been achieved with either standard ABVD or standard BIACOP had they been the choice that you made at the beginning of treatment. That's the way I see things unfolding today in terms of the management of advanced stage Hodgkin lymphoma. I've gone over things very quickly because I assumed that many of you were quite knowledgeable about this, and I wanted to point out the major themes. And I'd be happy to wrap things up here and move on to a period of discussion. I would like to thank my sponsors for inviting me to do this. It's a novel experience to talk to you through the computer. I hope that came across clearly, but it certainly has been delightful on my part to have a chance to review these results. Thanks very much for tuning in today.
Okay, thank you so much. I think there's echoing in my voice. Not? Okay, good. Thank you so much, Professor Connors. I think excellent presentation and comprehensive also review from different aspects. And while waiting for more questions from the audiences, I think I will start by few questions in the clinical part, and then we'll take few things also in your perspectives and your predictions for the future of Hodgkin lymphoma. Brentuximab AVD, I think with this major landmark trial with the Echelon showing the superiority of the brentuximab AVD for the ABVD, that was not translated to most of the clinical practice, and still we see ABVD in major or in other countries, even if the cost is something they can achieve, they did not change to the brentuximab AVD. Is that something to do with the toxicity? Is it something to do with the initial presentation about the modified progression-free survival endpoint, or is it still the cost in other countries?
I think it varies depending upon the setting. I didn't take the time to look at subsets of patients, but if one does do that and looks at the Echelon1 results, it's clear that at least in the early days of follow-up, that most of the benefit has been seen in the patients that have the worst disease. That's what you would expect. The patients with the worst prognosis are the ones where events are going to occur most quickly. But there it seems that the patients with multiple sites of extranodal disease or stage 4 disease are the ones that disproportionately benefited from the addition of the brentuximab. And my understanding is that gradually around the world, clinicians have been shifting to choose to use the addition of brentuximab along with AVD as an approach, particularly focusing on those patients with the worst prognosis disease. That said, I agree with you that cost is a major issue. The introduction of brentuximab dramatically increases the cost of treating the primary treatment of Hodgkin lymphoma. That, I think, has driven decision-making in a number of jurisdictions. And then finally, I think appropriately, when we already have a high level of success, when fortunately the majority of patients with advanced stage Hodgkin lymphoma can be cured, it is important for clinicians to make changes to their usual approach to this disease carefully and based on if you like, thoroughly explored evidence. And it takes a while for this to percolate into the community and for clinicians to become satisfied that the information they're receiving is solid enough that they should be making these changes. So we put all those together. I think we're gradually seeing a shift that will continue as the novel agents like brentuximab and later the checkpoint inhibitors are introduced into primary care.
Okay, good. Another question, do you think the brentuximab in the front line would overcome the predictive value of the interim PET as well as the escalation, de-escalation strategies, or say this is a one size fits all, give brentuximab and you don't have to be concerned about the positivity, negativity as interim or about the escalation, de-escalation?
Well, that was the point I was trying to make by showing the results when patients were treated with the brentuximab plus AVD. Now remember that those patients then received those agents all the way through their treatment. No change was made in their treatment based on the PET scanning. But when one reaches the end and looks at the progression-free survival, about 60% of the patients achieved a progression-free survival, even if the PET scan was positive after 2 cycles of treatment. That's a close rival for what was achieved in the SWOG study and in the RATHL study when patients were escalated up to escalated BIACOP. So for the moment, as best we can tell, using brentuximab all the way through the treatment achieves the same goal in the patients with PET2 positivity after 2 cycles. That is as far as we can go given the data that's available. We haven't had any trials yet examining the use of escalation or de-escalation based on interim PET scanning when the novel agents are introduced. But I explain it that way because of what I had earlier said, where I think the major accomplishment of planning your treatment based on interim PET scanning is to reduce toxicity. It doesn't achieve much in the way of improving outcome for the overall group of patients. It reduces toxicity, but you get to the same place as we were already getting before we started using PET-driven decision-making. I think the way forward to make things turn out better for these patients is with increasing the emphasis on the use of novel agents.
Okay, perfect. I think we have one questions which I published here from Dr. Amir Alim. What do you think of an approach to start ABVD, then if a positive PET, add brentuximab, escalate to brentuximab AVD?
Well, I think that's a fascinating idea, but it's, if you like, an untested hypothesis. I'd be concerned about an approach like that, because I think a lot of what is accomplished with our treatment of advanced stage Hodgkin lymphoma is actually accomplished in the earliest phases of treatment. And waiting to bring in the powerful additional agent that you hope is going to accomplish a lot until later, I think at least risks delaying its introduction beyond a point where its maximum benefit can be seen. So I certainly wouldn't take that approach outside of a clinical trial. I think that's, if you like, an experiment. And it's an experiment that hasn't been tried yet, and we don't have the results from trying the experiment, so I can't tell you what would happen. One might hope that you could reserve introducing the brentuximab until that point, and then selectively choose just the patients that seem most to need it. It's an attractive idea, but I would like to see it tested and verified to be an approach that works as well as the one that we can already achieve when the brentuximab is used all the way through.
Okay, perfect. Back up, I think you've mentioned about the brentuximab into the Ethera and the benefit, and compared to the benefit into the Echelon. Do you think all the patient, even advanced stages with, I would say, a favorable, let us say, according to the Hazen-Clever Index score, will all need that brentuximab? Because if you see the benefit of brentuximab as a single agent, or when it was combined with the salvage into the relapsed refractory, or with the nivolumab, the CR was almost doubling, and we've seen that maybe higher than what would you expect with the ABVD. Is it something to do with the biology of the Hodgkin lymphoma? That means those with the relapsed refractory, they have a more kind of aggressive disease needed brentuximab. Is it because most of the patients in the front line, they might have a favorable outcome regardless of adding brentuximab? Can we extrapolate anything regarding this issue?
You may have to help me by repeating part of the question again, but my first response to that is that it is clear that if you're looking for a specific statistical benefit, remember that you're going to see any benefit that's really there most quickly, and perhaps most largely quantitatively, in the patients with the very worst disease. And that's the way things have unfolded so far. So the patients, for instance, with stage 3 disease, there was less of a difference between the experimental and control arms in the Epsilon1 trial than was seen in the patients with stage 4 disease, or stage 4 with multiple adverse prognostic factors. But that's what you would expect to happen. It takes longer to see the difference in outcome when the disease is more favorable in the first place. So for the moment, we don't have any data that allow us to confidently state that there's genuinely a lower benefit or less benefit in the patients with more favorable disease. All we have is the necessity to follow patients for longer to see the longer-term outcome, to discern what actually happens to those patients. And for the moment, I don't know of any biological reason why there should be less actual benefit of a novel agent in patients with more favorable disease. It's just harder to see because of the structure of clinical trials. Now, I'm not sure if that speaks to your question.
Yes, yeah, exactly. That's very clear. Yep, thank
you.
So I think we're still receiving a question about the de-escalation. So here are two questions about why if we start with 2 cycles of brentuximab AVD, then de-escalate based on a negative PET. And I think you answered that outside the clinical trials. So, but would that someone, if they say we've started with 2 brentuximab, and then if it's negative, can we de-escalate to AVD?
Well, similar to the answer that I gave before, again, that's an interesting idea. In that case, you would be taking advantage of what I was saying. That is, what's given earliest, I think, has the most impact. Or stated differently, if you want to do better with something new, it's better to be in the treatment from the beginning. Whether all of the benefit that is going to be achieved from the novel agent can be gained or grasped If it's only used for the first 2 cycles, I just remains to be seen. It's an untested hypothesis. It certainly is an interesting idea. Would reduce the neurotoxicity, so it would achieve a desirable goal. And so you can envision the possibility of a Rathel-like trial in the future where the B that is dropped is not bleomycin, but in fact is the brentuximab. But lacking such a trial, I think it would be an error to leap to the assumption that that can be done safely. And think back, in giving ABVD, we went years and years and years continuing to include the bleomycin throughout the whole 6 cycles of treatment, and didn't think it a sensible strategy to drop it in a selected subset of patients with PET2 negativity until that trial was completed. I would want to see a companion trial that examined that strategy with the dropping of brentuximab before jumping to that with the hope that nothing will be lost in terms of overall outcome.
Okay, perfect. We'll take a few questions also here. Someone is asking, what is the role of the autologous stem cell transplant in a patient with a positive PET after 6 cycles of chemotherapy?
That's a challenging question. So let's think about this patient. The patient has had 6 cycles of our planned chemotherapy, whatever it was, and now their PET scan is still positive. If it's positive in an isolated area, I think the most attractive option is adding involved field radiotherapy. That's an examined question, and we have the results from German Hodgkin study trials demonstrating that there's a benefit to be seen in doing so. But what if the extent of disease is in the wrong sites or too wide for the safe application of involved field radiotherapy? Well, as best I can tell, if one uses a Duval score of 4 or 5, not 1, 2, or 3, but 4 or 5 at the end of the planned 6 cycles of chemotherapy, and don't do anything, about 80% of those patients will eventually relapse. One could then think that perhaps that justifies immediately turning to high-dose chemotherapy and autologous stem cell transplant. On the other hand, interestingly enough, the data that we have indicates that at least 20% of the time, and perhaps somewhat more often, that PET scan is falsely positive. In fact, following those patients, the PET scan eventually turns negative over time. And so embarking on a strategy in which you automatically turned to high-dose chemotherapy because the PET scan was positive would mean treating at least 20% and perhaps more patients who don't need it at all. I think that the toxicity of high-dose chemotherapy is sufficiently high that I would prefer not to jump in and treat all those patients knowing that 20% plus patients don't even need it. Especially because I don't think that anything will be lost if one observes the patient carefully and moves to the high-dose chemotherapy and the autologous stem cell transplant as soon as there's definite evidence of persistent disease, which becomes definite because there's evidence of progression. So the strategy that I follow and that we follow at our center in those patients who can't be adequately treated with involved field radiotherapy is close observation with CT scanning, not serial PET scans, but CT scanning. And if there's any evidence of progression of disease, moving to high-dose chemotherapy and autologous stem cell transplant at that point, that spares over-treating patients, treating some of the patients with the false positive PET scans. But it does mean some very careful watching and to make your decisions.
Okay, perfect. Another question, this is from Dr. Ahmed Al-Askar. Where do you see the future of the Hodgkin lymphoma in the era of the novel agents at the checkpoint inhibitors?
Well, I think we already know that the checkpoint inhibitors have a very important role to play in relapse disease. So patients with relapse, either before or after receiving high-dose chemotherapy, do seem to profit from the use of the checkpoint inhibitors. and strategies integrating them into the management of those patients are already being tested and moving into clinical practice. But just as it was necessary to move from phase 2 trials to the Ethera trial to primary treatment trials in the Epsilon1 trial with brentuximab, the same sets of tests need to be performed for the checkpoint inhibitors. Fortunately, that's already being done. So currently, the intergroup in the North America is testing the comparison of AVD plus brentuximab versus AVD plus nivolumab. And this is going to directly test and find the answer to the question of what can be achieved by adding the checkpoint inhibitor to the primary treatment of Hodgkin lymphoma. I think that we need to see the results from that trial to know how it should affect the standard management of patients off trial. So I hope that the trial accrues quickly and gets us an answer relatively quickly. In the long run, I would actually put the most hope on adding both novel agents. That's not being tested in that particular trial, and so far as I know, not yet being tested elsewhere. But I would think we'll move eventually to a day when one brings in both brentuximab and the checkpoint inhibitors to primary therapy and see what that's going to accomplish. And I'm hopeful about it because the two novel agents, the brentuximab and the checkpoint inhibitor, work by entirely novel mechanisms, separate mechanisms that could easily be additive or even synergistic.
Okay, perfect. Have two questions about the predictivity of the PET scan. This is a one by Dr. Salem. Is a PET scan reliable enough as a biomarker to predict outcome and design escalation, de-escalation strategies?
Well, I think yes is the answer. We've now examined the accuracy of the PET scan in many different situations, but I did point out that one needs to carefully focus on how the PET scan is interpreted. So you saw from what I was presenting that if you say for advanced stage Hodgkin lymphoma, if you start with ABVD, that one conventionally can use a Duval score of 1, 2, or 3 to declare that the PET scan is negative and reserve calling it positive for patients who have PET scans of 4 or 5, Duval score 4 or 5. However, if you wish to use the strategy that had been employed in the AHL 2011 trial, the LYSA trial, there they relied on a novel definition of what constitutes a positive PET scan. So to return to the language of the question, the PET scan was reliable in that situation, but reliable only if you use the definition of calling it negative with Duval scores 1, 2, 3, or 4 with a relatively low SUV, and not calling it positive until you had a score of 4 with a high SUV or 5. That's how you make it reliable, by doing the test that marries the actual outcome to the long-term outcome for the patients. Escalation and de-escalation, I'm not a particular fan here. The reasons is what you heard me hinting at. I think escalation is only going to be useful for a rather small minority of the patients, and it doesn't completely answer the question. You don't suddenly start curing all those patients. And de-escalation is potentially very useful, but all that does is reduce toxicity. That doesn't cure more patients. And my overall goal here is to cure more patients.
Okay, perfect. And I think that's another question of the same. So any potential, would say, other biomarkers or other tools better than the PET to predict?
Well, we're still searching for them. So the two ways in which these are being searched for, I can tell you about, are that you can get more information out of PET scans than we currently typically do using simply the Duval score. And so ways of looking at the total uptake across the entire set of tumors that are persistent is a way of quantifying the value of the PET scan that is still to be fully explored. And this can be called the total metabolic score or other measures. That approach is being explored experimentally and may ultimately prove to be more reliable and more useful. One can look at the degree of change in the SUV rather than just a yes-no question about SUV, a different way to interpret the PET scan. But I think the greatest potential is actually in biological assessments. And we've not found a particular biological marker or set of markers yet that has the reliability that we would like it to have to predict outcomes, but that doesn't mean that we won't be able to do so in the future. So for instance, a very interesting technique is to look at circulating tumor DNA. It turns out that, as has been shown for many different cancers, this can also be a valuable test for Hodgkin lymphoma. And so perhaps the use of the persistence or eradication of circulating tumor DNA related to the primary tumor will be of great usefulness in the management of patients with Hodgkin lymphoma. Other biomarkers are still to be explored. I know our research group has looked at single cell genomics and also the gene expression profiling of these tumors. All of this biological exploration needs to carry on, and some of it may well prove to be sufficiently promising in the future that we'll have a better assessment tool to tell us which patients are going to do well and which ones aren't, and which patients are responding well to the treatment and which ones aren't.
Okay, perfect. This is a question about how would you treat elderly patients with advanced stage Hodgkin lymphoma outside clinical trial?
That's an important question because depending on who you call elderly, and remember that I'm over 70 years old, so you have to be careful of what you call elderly. But let's say we'll call it over the age of 60 as a cutoff, because I think there's general agreement that one shouldn't be using highly escalated treatments like escalated Biacop for patients over the age of 60. So patients in that age range, over the age of 60 or 70, the first step is to assess their overall health, because all patients are not alike. We all know that. Some patients are a very healthy 60 or 70-year-old with no organ compromise, good health, no comorbidities, and they are likely to be able to tolerate treatments like ABVD or brentuximab vedotin plus AVD reasonably well and can be treated that way. But there will be patients who are elderly and frail, and these patients require a tailored approach. So to summarize it, I would say the assessment should not be just chronological age, but should actually be based on performance status and comorbidities. And patients with a good performance status and without major comorbidities and organ compromise can actually be treated with ABVD, and the B can either be bleomycin or it can be brentuximab vedotin, and one needs to take care because the pulmonary toxicity from bleomycin or the neurotoxicity from the brentuximab will be greater in older patients, and more care has to be exerted in their management. If, however, the patient is frail, what you do depends on how they're frail. So, for instance, a patient with major compromise of cardiovascular system shouldn't be given adriamycin or doxorubicin. And so that elderly patient with heart disease needs to have the agent, the doxorubicin, removed and something substituted. At our institution, we use etoposide as a substitute. Or alternatively, a patient may already have pre-existing compromise of their pulmonary system. Patients with chronic lung disease often can't be given bleomycin safely. So you know from the beginning the agent has to be dropped. So the best I can do in a short answer is to say that for elderly patients who are frail, tailoring of the treatment is the most sensible thing to do. And one tailors by avoiding the agents that are most likely to cause inordinate toxicity because of underlying comorbidity. Beyond that, I guess I have to address the patients who are just frail overall. There's nothing, no organ specifically disordered, but they're just not doing very well. And all I can say there is that's the art of oncology. One wants to then intervene with a regimen that you tailor for that particular patient. So older combinations, one's called Chlorvip, in which chlorambucil and vinblastine are used in the old MOP type schedule, sometimes can be suitable when you have to avoid anthracyclines and pulmonary agents. That kind of tailoring of the treatment would be the next step I would think of. And then finally, there will be patients who are quite elderly and quite frail, and it's important to simply admit that we can't accomplish the same thing for a patient like that. And what one might need to decide right from the beginning is that quality of life, prolongation of life, as opposed to cure, are the two goals that you should fasten on. And patients like that may be best treated with a single agent to control their symptomatic disease for as long as one can. And then you're into the business of managing the patient like you would a patient with an advanced malignancy of almost any type, where we don't have effective curative treatment, but we do have the tools that we can at least temporarily use to control symptomatic disease.
Okay, perfect. What do you think about the sequential? Andrew Evans reported this study of the 2 brentuximab followed by 6 ABVD followed by 4 brentuximab in elderly frail patients, aiming to debulk the disease and improve the quality of life, then giving the AVD. Is that something was done MBC, or just combining the brentuximab with the AVD based into the fitness of the patient?
Well, I think that the approach that you're referring to, where lead-in brentuximab or alternatively lead-in checkpoint inhibitor, is then that is either continued or one then switches over to more traditional agents like AVD. Those are the kinds of approaches that I'm talking about when I say tailoring the approach to the needs of the specific patient. I think if you step back and look at the big picture, in making a choice like that, what you're saying is that no standard treatment that one might otherwise be using is suitable for this patient. And that means that whatever approach one takes needs to be crafted specifically aimed at the individual needs of that particular patient. And then choosing perhaps to use an approach that starts with one of the novel agents and then incorporates standard agents, or chooses to use the other novel agent. These are all sensible things to try, remembering that you're essentially conducting an experiment on one patient and trying to figure out what you might be able to deliver. Fortunately, at least some of the time, approaches like that even do have the potential to be curative. And so initial brentuximab or initial checkpoint inhibitor followed by traditional agents does cure some patients. And if you find a patient where you think you can do that safely and they aren't a candidate for a more standardized approach, that would be a sensible thing to try.
Okay, perfect. We have 2 more questions and then we'll finish because we are approaching the time. Do you do a pulmonary function test as a baseline, as a standard test for all the patients receiving ABVD?
Well, I have to start by reminding everyone that the pulmonary function testing is not a particularly reliable tool for detecting early pulmonary disease as it's developing, so as to avoid it escalating into much more severe disease. So since it has very limited usefulness in that situation, it calls into question whether there's much value in using it as a standardized test before one starts the treatment. I think the important thing to do is to assess the pulmonary reserve that a patient has. So one way of thinking about this that I try to urge in my trainees is to think when they're looking at the patient, think, what if the very worst happened? That is, let's suppose we start treatment and this patient loses a third of their current pulmonary function. Will they be able to tolerate that? Well, an entirely healthy person with normal pulmonary function and pulmonary reserve can do that. If they were so unlucky as to have that level of compromise, they could still be managed through it and get on to a successful outcome. But if you're looking at a patient who already has pulmonary compromise, and one then reduces them by a further third, and they're going to get into a lot of trouble, that's the kind of patient to think very carefully before using a possibly lung toxic agent, and perhaps even avoiding it. So if you can assess the patient by talking to them, perhaps examining them as they climb stairs or perform some modest exercise, and assess their pulmonary function, and convince yourself that it appears to be normal or near normal, then I don't think you gain anything by doing pulmonary function testing. You already made your assessment. If you need it, if you think that you don't have a reliable understanding of this patient's pulmonary function, then certainly doing the pulmonary function test may give you a warning signal that you should be paying attention to. And then you're looking for a patient who's got pre-existing compromise, and it's compromise that is not simply due to disease. Remember that Hodgkin lymphoma in the lung or Hodgkin lymphoma in a large mediastinal mass will also interfere with a patient achieving normal pulmonary function. But if you think it's due to a pre-existing condition, then you should be very wary of using a potentially lung toxic agent.
Okay, perfect. And will be the last question. What is the preferred, maybe second-line treatment for refractory Hodgkin lymphoma? Maybe it's outside this.
Okay, I will answer that. And please, I'm not trying to be flippant or minimize the importance of the question when I say that it doesn't matter. I say it that way because I think that if a patient has refractory, or I'll add in relapsed Hodgkin lymphoma, that the most important thing is if you can possibly get that person to high-dose chemotherapy and an autologous stem cell transplant. If you can do that, then you give them the best chance of being cured. How you get there, I don't think matters so much. I think most of us have developed a standard approach where we rely on one particular regimen. At our institution, we use the combination GDP, gemcitabine, dexamethasone, cisplatin. But ICE or DHAP or a variety of regimens, and more nowadays we're seeing people add brentuximab or added a checkpoint inhibitor in the second-line treatment. I don't think ultimately that those standard dose second-line treatments make that much difference. What's important is the patient get to the high-dose chemotherapy. If one gives second-line treatment, say GDP, and the person has a splendid response, their PET scan becomes negative, they have a much more favorable prognosis beyond that point, and they're more likely to sustain their response to the high-dose chemotherapy and autologous stem cell transplant. However, if they don't have a particularly good response, if they say have only a partial response, or even if they don't demonstrate very much response at all, they still should proceed to the high-dose chemotherapy and stem cell transplant, because at least some of those patients, a much lower fraction of those patients, but some of those patients can be cured by the high-dose treatment. So if the questioner is asking me, what is the second-line treatment for refractory or relapsed Hodgkin lymphoma? Definitely, it is high-dose chemotherapy and an autologous stem cell transplant, if that can be given with any degree of safety. What lead-in chemotherapy one uses before that is done, I think matters much less. And I would say, whatever you're already doing, continue to do it, because you have experience with the toxicity that that particular approach will induce, and you know best how to manage it, and concentrate on getting the person onto the high-dose treatment that they need.
Okay, Dr. Connor's great presentation and thoughts and interactive discussion as usual. Thank you so much again for your time, and thank you for sharing your experience. And my apology for taking this long time, but everyone is interested and motivated to have the discussion. I still received more of the questions, so hopefully maybe when you visit us in Jeddah, hopefully maybe next year in the conference we'll have a more maybe side discussion about all these things. So thank you so much, and have a good night.
Well, thank you very much for inviting me. I look forward to my chance to be there in person, and I hope this was useful for the listeners. Bye-bye now.
Sure. Thank you. So this is just another announcement for next week, how I treat AML. Again, I would like to thank the SSBMT and Dr. Ahmed Al-Askar for organizing this series of webinars, and hopefully we'll see you on time for next week. Have a good night and see you all.